Welcome back to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm Amanda Mixon, here with Wendy Simmons, and this is part 2 of our EULAR Osteoporosis RhAPP Up Series. In our last episode, we covered some great data, and today we're going to dive in more. So let's go ahead and get started. I'm going to start us out with Abstract 1. Do glucagon-like peptide-1-based therapies, or GLP-1s, increase the risk of adverse effects in those taking oral bisphosphonates for osteoporosis? An overview of this study. This was a retrospective observational cohort study evaluating whether patients receiving both GLP-1 based therapies and oral bisphosphonates for osteoporosis experience increased rates of bisphosphonate related adverse events compared with patients receiving oral bisphosphonates alone. The background of this study was that GLP-1 receptor agonists and dual GLP-1 GIP agonists are increasingly used for diabetes, obesity, cardiovascular protection, and kidney disease. Because these medications delay gastric emptying, concerns exist regarding altered absorption and tolerability of oral medications, including oral bisphosphonates used for osteoporosis treatment. This study aimed to evaluate whether concomitant GLP-1 therapy increases the risk of adverse outcomes associated with oral bisphosphonate use. The methods of this study were that investigators conducted a retrospective cohort study using the TriNetX database, which includes electronic health records from more than 142 healthcare organizations globally. Patients receiving oral bisphosphonates with GLP-1 based therapies were compared with matched patients receiving oral bisphosphonates alone. Propensity score matching accounted for demographic and clinical co-founders. Outcomes were assessed over 5 years and included hypocalcemia, atypical femur fracture, osteonecrosis of the jaw, vertebral compression fracture, acute kidney injury, atrial fibrillation, polyarthralgia, and other adverse events. The results were after matching, more than 63,000 patients were included in each cohort. Investigators found no significant increase in the risk of vertebral compression fractures, atypical femur fractures, or osteonecrosis of the jaw among patients receiving both GLP-1 therapies and oral bisphosphonates. However, patients receiving combination therapy demonstrated statistically significant increases in hypocalcemia, polyarthralgia, acute kidney injury, atrial fibrillation, conjunctivitis, uveitis, scleritis, and urticaria compared with patients on bisphosphonates alone. The authors' conclusions were that concomitant GLP-1 based therapy did not appear to increase the risk of most feared bisphosphonates related complications, including atypical femur fracture, vertebral compression fracture, or osteonecrosis of the jaw. However, the observed increases in several other adverse events suggest clinicians should monitor patients carefully when these therapies are used together. The authors noted that additional long-term studies are needed to further evaluate safety in this rapidly growing patient population. This is super interesting information. And you being kind of the osteoporosis guru that I obviously consult all the time when I'm talking about my patients, what do you make of this?
Amanda, this is so appropriate. I think most perfect timing and definitely something to follow, I believe, as well. I love this as well for a topic here with an abstract. I am having more and more patients, obviously, that are on GLP-1s and treating for osteoporosis, and questions coming up with regards how that GLP-1 is going to affect potentially the outcome of their next bone density, their bone health, effectiveness of the therapy that I am using as well. Um, so I definitely important. I think there's a lot of things to consider in our patients that are on the GLP-1s as well, with not only just sort of altering their diet, their lifestyle, measures, quality of what that food is that they're eating as well. I think this is very interesting information with these AEs occurring in combination, though not alarming it, no alarms sounding here with what we also follow for concerns with just the bisphosphonate therapy, the jaw necrosis, the atypical fractures as well. I feel that it's interesting about the hypocalcemia. It's looking like there is delayed gastric emptying. We have concerns about using those oral bisphosphonates alone uh, for fear of reflux into the esophagus and causing esophageal ulceration. So that is certainly not listed here, but delayed gastric emptying, leaving that bisphosphonate in the gut for so long, certainly questions of effectiveness with absorption. Calcium's also absorbed in the upper gut. So I find it interesting that hypocalcemia would be listed on here as an AE. If what is the calcium doing? Is the calcium sitting there as well? So certainly some more information with regards to absorption. Vitamin D we know is absorbed in the lower gut. That patient's taking their vitamin D, there's delayed gastric emptying. Then is that vitamin D getting into the lower gut? What's happening? That vitamin D basically is the vehicle to get that calcium into the bones. So certainly some mechanisms there, as we know that calcium and vitamin D are building blocks. Metabolic issues. I mean, this is a metabolic topic as well. Um, Kidney injury, that also being mentioned here would be concerning with a patient also having osteoporosis. Patients that would be having kidney injury, certainly you would want to be looking at the continuation of oral bisphosphonate or bisphosphonate, uh, you know, filtered through the kidney as well. And, you know, is that tied into metabolic reasons as well? So I think a little bit more data looking here as well. I think that this is a great platform for more GLP-1 studies because there are a lot of questions out there and limited attention to data. This is certainly something that I feel like all of us in our clinics could almost do our own type study. What is happening with that patient? Maybe this is an answer. Some of those patients that we get back in clinic that we repeat a bone density, and it is declining, or nothing has changed, or there's some absorption concerns there as well. I don't know all the complete mechanisms of action that would be tied in together here with both of the uh, medications being used, the GLP-1 and then the oral bisphosphonate. I think this is exciting, leading to potential other studies with what about infused bisphosphonate? What about, our other therapies if you're using an anabolic uh, or, other antiresorptives? What does that look like with a GLP-1 as well? And patients are coming into the clinic most definitely asking these questions as well. I think really, doing our due diligence and counseling that patient still with the basics of osteoporosis with nutrition, calcium intake, vitamin intake, activity level, resistance as well. Are they tolerating the calcium? What is happening there? I don't know if, what does it look like? Are these AEs that are occurring with these medications in combination uh, also happening in patients with GLP and on the GLP-1 side without the bisphosphonate? I think putting that information in here, that might be another arm in a study that would be good to look at as well.
Absolutely. You made such, incredible comments and thoughts on this. And again, I think the biggest thing is, more studies are needed. And it will be kind of interesting to see because to your point, more and more patients are coming in on GLP-1s. And I think these are wonderful therapies for patients, but we have to think about when a patient comes in on a GLP-1, So many factors, like who's prescribing the GLP-1? Are they getting it online? Where there's maybe not as much counseling being done to talk about your nutrition and continuing to exercise and, certainly that resistance exercise that is needed to maintain, bone density. And so, and to your point, like getting that adequate calcium, vitamin D daily, and then not to mention the gastric emptying. So I think this just highlights that, we are in another position where rheumatology APPs, I think in particular, are so good at educating our patients. And so that when you see somebody that's on a GLP-1, you can say, hey, talk to me about this a little bit. Like, are you still kind of getting adequate nutrition? Like, let's talk about your exercise, your weight bearing exercises that you're doing to help maintain your bones. And to your point, I think the other thing is, will patients on GLP-1s, should we be more thinking about an injection or an infusion for those patients to try to potentially limit some of these, AEs? Again, more to come, right?
Absolutely, Amanda, and that's definitely the point of the abstract as well, is looking at what type of increase in adverse events are occurring. So what if you switch from that oral mechanism of action to a different type of mechanism of action? Would you still see some of these same adverse events? That I think definitely would be another good abstract change. Change the therapy now that you know what the results are with the oral bisphosphonates, if needed. I think that also that we potentially could get a lot more information uh, through other studies by having some cross conversations with metabolic, or GI people as well, as to what type of effects there are with the GLP-1s as well. So in the end, in the future, I feel that we all can come together, look more about what is happening in these patients with osteoporosis that are using them as well. There's no doubt that the GLP-1s are uh, completely positive for our patients in all our disciplines as well. It just might be with regards osteoporosis, what type of mechanism of action are you going to use on the osteoporosis side? So I think we could certainly work there with patients as well. Um, this is great. It's something I have my eye on in clinic. Something that I do continue to take extra notes on with these patients as well, to follow them. I've got a few patients that I'm following that are doing well. They're not having any type of AE, so that is positive. But it will be good, I think, in the end to see what is the DEXA, what are the bone results going to be in the long run on some of these patients. So more topics, more answers. Excellent. So now we'll go into abstract 2, AB0538, bone mineral density in patients with rheumatoid arthritis under different therapeutic strategies. Overview of study. This prospective observational study evaluated changes in bone mineral density in patients with rheumatoid arthritis receiving various biologic and targeted synthetic disease-modifying therapies over a 12-month follow-up period. Background and purpose in this abstract: patients with rheumatoid arthritis are at increased risk for osteoporosis and bone loss due to chronic inflammation, glucocorticoid exposure, reduced mobility, and altered bone metabolism. Emerging evidence suggests that biologic and targeted synthetic DMARDs may positively influence bone remodeling beyond simply controlling joint inflammation. This study aimed to assess how different RA treatment strategies impact bone mineral density over time. Methods used in this study: investigators conducted a longitudinal observational study involving 75 patients with rheumatoid arthritis treated at a rheumatology center in Mexico. Bone mineral density was assessed using DEXA scans at baseline, 6 months, and 12 months at both the femoral neck and lumbar spine. Patients received a variety of these therapies, including TNF inhibitors, IL-6 inhibition, rituximab, abatacept, and baricitinib. Disease activity inflammatory markers and changes in bone mineral density were evaluated throughout follow-up. Results showed overall changes in bone mineral density were modest, but trends toward preservation or improvement in bone mineral density were observed with several therapies. Baricitinib, rituximab, golimumab, and certolizumab demonstrated the most favorable effects on bone density, particularly within the lumbar spine. Baricitinib and rituximab showed the greatest increase in spinal T-scores, suggesting possible protective effects on trabecular bone. In contrast, abatacept was associated with decrease in bone density at both evaluated sites. Tocilizumab and adalimumab demonstrated worsening bone mineral density, specifically at the femoral neck. Despite good overall disease control, some patients continue to experience aggressive bone loss. Authors' conclusion: the study demonstrated that different RA therapies may have varying effects on bone mineral density, with several biologic and targeted synthetic agents showing potential benefits in preserving bone health. The findings suggest that even in patients with controlled rheumatoid arthritis, ongoing monitoring of bone health remains important, and treatment selection may influence long-term skeletal outcomes. Longer-term studies are needed to better define these associations. Completely agree. Great topic. Certainly not a large population in the study. However, very, very interesting. In these patients, we cannot, again, see skeletal matrix. One point I feel that I can bring out here as well is where you might want to see great increased scores. And I mentioned baricitinib and rituximab showed the greatest increases in T-scores in the spine, suggesting protective effects on trabecular bone. So the trabecular bone, as we know, is that central bone. It's the core bone. The cortical bone's outside shell. The trabecular bone's the site that's going to lose the most bone density first in osteoporosis, the fastest. So we would potentially see, improvements there quicker when we use therapies. Amanda, honestly, I can be honest, I am not sure what to completely make of this. I'd love to hear your comments as well. Again, I agree with more studies, but what do you feel? Do you feel it's worth potentially someone looking into some of the therapies?
Absolutely. I am so confused by this study, I have to be honest. I have never picked a therapy based on what I thought it was going to do to somebody's bone density. And so, um, you kind of really wonder, who were the particular patients? What were those characteristics? This particular study gave me more questions than answers. And I think it's very interesting, but I think we need a lot more data, a lot more studies to really tease this out. Because I can't say that I would, in my brain when I'm seeing a new RA patient say, "Oh, let's put them on rituximab," so as a first line, I just, because their bone density. So I think we need a lot more information.
Absolutely. I completely agree. And I have so many questions with myself came out of this as well. And which brings you to the point of really how much time would a clinic have when you look at all these therapies that we have for patients with rheumatoid arthritis. I think the point being, I certainly agree and have followed and understand that patients with rheumatoid arthritis are going to have a higher risk of osteoporosis. That's certainly what we're taught, what's on the FRAC score as well. However, the approaches to biologic or DMARD therapy certainly could be questionable. 75 patients in here, and also the time frame. It's a 12-month, I guess it's a 12-month follow-up period here as well. Osteoporosis certainly doesn't occur overnight, doesn't repair overnight. I tell my patients that. We still struggle sometimes being able to do bone densities at the 1-year mark. to 2 years. Certainly, you can do them more often in studies. Uh, Again, just so many questions. I think this would be one that I would feel much more difficult to really think about on a daily basis in my clinic. As you mentioned, we see so many patients, so many that have rheumatoid arthritis. We're working with so many different classes of medications to treat RA. I feel this would be difficult. Kudos for the attempt.
Absolutely.
Yeah, and really, I don't know that there's much impact on patient care. I really don't. I could not comment on that.
I totally agree. We're definitely on the same page there. That's a wrap for part 2 of our EULAR Osteoporosis RhAPP Up Series. Thank you for listening, and don't miss part 3, where we will cover even more data from the 2026 EULAR Congress.